This is Dr. Mimi Lamb from Metro Health Medical Center at Case Western Reserve University, and I would like to help you understand the pathogenesis of metabolic alkalosis. The key to understanding this disorder is recognizing that it has two phases, generation and maintenance. Generation is what causes the alkalosis in the first place, and maintenance is what keeps it from being corrected. Metabolic alkalosis is characterized by a high pH and elevated serum bicarb level. One common cause of this disorder is hydrogen ion loss, for instance through vomiting or nasogastric suction. Here the hydrogen ion and bicarb equilibrium with water and CO2 is disturbed by losing hydrogen ion through the stomach, so that bicarb is left behind, raising the serum bicarb level. Another cause of metabolic alkalosis is addition of bicarb to the blood, for instance because a patient takes baking soda for indigestion or because we overestimate the amount of bicarb that needs to be given during cardiopulmonary resuscitation. The process of bicarb reabsorption is central to understanding metabolic alkalosis, so let's review that. In the proximal tubule and collecting duct, sodium is reabsorbed and hydrogen ion is secreted. Secreted hydrogen ion combines with filtered bicarb in the tubular lumen, forming carbonic acid, which splits into water and CO2. These non-ionized molecules can be absorbed across the lipid cell membranes, and once inside the cell can recombine and split back into hydrogen ion and bicarb. The bicarb is transported into the blood, while hydrogen ion is available to be secreted again to help carry more bicarb back into the cell. So the more hydrogen ion you secrete, the more bicarb you can reabsorb. Normally, serum bicarb concentration is maintained at a fixed level by the kidneys. The renal tubules generally operate at their Tmax or transport maximum for bicarbonate so that they reabsorb virtually 100% of filtered bicarb to keep the serum bicarb at a normal level. Here you can see that serum bicarb is maintained at a level of 26 milliequivalents per liter. Below that level, all bicarb in the filtrate is reabsorbed so that none appears in the urine. If serum bicarb increases for any reason, since the tubules are already operating at their Tmax, they can't reabsorb any more bicarb, and so the rest is spilled into the urine, and serum bicarb rapidly returns to normal. So once an alkalosis has been generated and serum bicarb has increased, remember that in order to maintain the alkalosis, the Tmax for bicarbonate, reflecting the tubule's ability to reabsorb it, has to be increased above normal. And what causes that to happen? It happens when the process of tubular hydrogen ion secretion is accelerated, which in turn can happen when sodium reabsorption is increased and the activity of the sodium hydrogen ion antiporter is increased. Think of the maintenance of a metabolic alkalosis or the inability to correct the alkalosis as being blamed upon things that cause this antiporter activity to increase, such as volume depletion, increased mineralocorticoid secretion, and potassium depletion. As you'll see, they're often interrelated. First, volume depletion increases sodium reabsorption throughout the nephron, mediated by increased activity of both the renin-angiotensin-aldosterone system and the sympathetic nervous system. The tubules become very avid for sodium, and the more sodium that's reabsorbed, the more cations, potassium and hydrogen ion, are secreted. And as we just said, the more hydrogen ion that's secreted, the more bicarb can be reabsorbed. Second, increased mineralocorticoid secretion. In the collecting tubule, aldosterone increases sodium reabsorption through activity of the ENaC or epithelial sodium channels. Reabsorption of cationic sodium leaves negative charges in the lumen and drives the passive secretion of the cations potassium and hydrogen ion. Third, potassium depletion. When sodium reabsorption is especially active for the reasons above, cation secretion is also active. Initially, potassium is the main cation secreted because there's a lot more potassium than hydrogen ion in the cells. But if potassium stores become depleted, potassium secretion decreases and hydrogen ion secretion increases more, making it possible to reabsorb even more bicarb. So again, remember that anything that increases hydrogen ion secretion increases bicarbonate reabsorption, keeping serum bicarb high and helping to maintain an alkalosis. Now let's apply what we've just talked about by quickly looking at 3 clinical examples of the generation and maintenance phases of metabolic alkalosis. In example number 1, a person takes baking soda or sodium bicarbonate as a home remedy for acid indigestion. Too much of this may result in a metabolic alkalosis as the serum bicarb level is increased by the consumption of baking soda. However, the alkalosis will not persist because the kidneys, already working at their Tmax, will reabsorb bicarb to a serum level of 26 milliequivalents per liter, and the excess will be spilled in the urine. This is an example of a generation phase of alkalosis without a maintenance phase. In example number 2, vomiting occurs for several days, resulting in alkalosis because of hydrogen ion loss from the stomach. Serum bicarb level increases, and initially the extra bicarb is excreted to maintain acid-base balance, as in example 1, but as the vomiting continues, the patient becomes volume depleted so that ECF volume preservation becomes the kidney's top priority at the expense of everything else. Now, tubular sodium reabsorption is increased, and initially lots of potassium appears in the urine. As potassium depletion begins to develop, hydrogen ion secretion increases, making possible more bicarb reabsorption so that the high level of serum bicarb can be maintained. This is an example of a generation phase occurring first and a maintenance phase developing over the next several days. So the treatment here is to stop the vomiting, replete ECF volume and potassium stores, and allow the kidney to normally excrete the excess bicarb and correct the alkalosis. In example number 3, a patient with severe heart failure and pulmonary edema is given a large dose of IV Lasix or furosemide, a loop diuretic. This increases salt and water excretion over the next few hours and allows edema and pulmonary edema to be relieved. But because the Lasix works in the ascending limb of the loop of Henle, it results in increased excretion of only sodium, potassium, chloride, and water. The bicarbonate in the ECF, initially 25 milliequivalents per liter in 14 liters, or 350 milliequivalents total, now finds itself in a smaller volume, say 11 liters, so 350 milliequivalents in 11 liters is now at a concentration of 32 milliequivalents per liter, constituting a metabolic alkalosis. However, because of volume contraction with the rapid diuresis, the kidney again quickly becomes avid for sodium, and again sodium is conserved at the expense of potassium and hydrogen ion secretion, preventing the correction of the alkalosis and instead maintaining it. So this is an example of contraction alkalosis where the generation and maintenance phases develop very close together and the alkalosis cannot be corrected until the diuretic dose is stopped or reduced and potassium is repleted. So in summary, metabolic alkalosis may result from direct addition of bicarbonate to the blood or from generation of bicarbonate by hydrogen loss from the body. Once an alkalosis develops, it will automatically correct itself because the renal tubules have a maximum amount of bicarbonate that they can normally reabsorb from the filtrate, and increasing the amount in the filtrate only results in excess bicarbonate being excreted in the urine. If a maintenance phase occurs with an increase in sodium reabsorption, then increased potassium and hydrogen ion secretion occur, often followed by potassium depletion and a further increase in hydrogen ion secretion, allowing more than normal bicarbonate reabsorption, which in turn allows serum bicarbonate to be maintained at a higher than normal level instead of being excreted in the urine. So if you understand the generation and maintenance phases of metabolic alkalosis, you should now be in good shape to go and read in detail and understand about its causes and treatments, some of which are listed here to whet your appetite. And now, please go and read.